welcome to our very first breakout for patient access. And I'm going to just maybe, if I can, go through the list. And I'd love to have you introduce yourself and your organization and your role within the organization. And if it's okay, since we have only a few participants, I'll just go down the list and ask that you introduce yourself. So Eric, I'll start with you.
Sounds good. My name is Eric Soto. I'm with Legacy Health. I'm based out of Legacy Mount Hood. I've been with the organization now for, I think, 5 years, just over 5 years. And in my current role at Mount Hood, I guess just over coming up on 2 years here.
Great. And Kelly Hooper, I'm so excited to see you on. How about an introduction from you?
Thank you, Kelly. Nice to meet you, Eric, so far. Actually, can you guys hear me?
Yes.
Probably not. I thought unstable. Sorry. It's not working.
Oh, we can hear you, Kelly.
Stable.
Well, we may come back. Yep, we can hear you.
We can hear you.
I'm so sorry. I guess, the internet connection. Here we go again, but I'll be quick. I'm Kelly Hooper. Oh, you can? Okay. That's great. Thank you. Well, it's nice to be a part of this. You might be able to hear my child as well in the background, but oh my gosh, I'm so sorry. Daddy. Oh, you guys should really pick another person. Okay, I would get out and shut the door. I'm so sorry. I'm Kelly Hooper, and that's probably good enough, but really nice to meet you. I'm really just here to learn and listen to your pain points and try to capture that, because that's what we're doing at our organization. And Amanda, I spoke to Evan last week, and he kind of shared some things, so I'm just trying to educate myself in the midst of the chaos. So good to see all of you.
Yes, you too, Kelly. We expect children and animals, so yeah.
That was both in one.
Good. Thanks, Kelly. Good to see you. And Tara.
Hi, everybody. My name is Tara Niles. I am the Patient Access Manager over ED registration and admissions at OHSU. I have been in patient access for over 13 years, and I've been in my current role at OHSU for just a little bit over a year, just in time for a pandemic and for fires and learning to juggle working from home and being in the office. So it's been a great first year.
Oh, Tara, well, if you can get past this year, you can get through any year. And are you
yes.
Do you live in a risk area? I think
yes,
you might.
I sure am. I'm actually looking outside right now going, okay, how soon do we leave? Because the smoke is pouring into my house right now.
Oh.
So the eyes are burning.
Oh, that's awful.
Yeah. It's great. Living every minute of this. Can't wait for 2020 to be over.
Oh, no kidding.
Yeah.
Well, you stay safe, Tara, for sure. Keep us posted.
If I duck out, it's for a good reason.
Yeah, no, safety first for sure. But we'll be thinking about you, me especially.
Thank you.
Amanda.
Hello. I'm Amanda Gordon. I'm Director of Patient Access, Financial Counseling, Customer Service at Legacy. And Eric is my right-hand man, so I'm really excited that he's helping with this, leading this session. And we're excited to talk to folks specifically about patient access and financial counseling and pain points and networking some more. I often reach out to Christy at OHSU, so it's nice to make the connection with you, Tara, too. So anyhow, just excited to learn more and happy that we could be here today.
Awesome. Thanks, Amanda. And then Molly. I see Molly, you're still on mute. I don't know if you're able to unmute and introduce yourself. Molly may not be able to do that. So I know, Molly, you're with Columbia Memorial, and you're out in Astoria, maybe you could even just type your role in that organization in the chat and we'll meet you that way. And then Hayden, while we're waiting for Molly to see if she's able to answer, do you want to introduce yourself too? I know you're a big help for this session, but also actively engaged with Oregon HFMA.
Absolutely. Thank you, Kelly. Hi, I'm Hayden Reese, and I'm on the technology committee. So I work with Haas Group and Professional Credit, who I believe they're sponsoring again as well. But yeah, I'm here in the background, just making sure that everything runs smoothly. And what I do is work on digital engagement strategies for revenue cycle management. So we have set up we're setting up automated email and automated text messaging. And I help out leading some of those projects as a manager for the development team and just bridging the gap with operations. And it's a really great time at Oregon HFMA. Really so glad to have Kelly leading this session today.
Good. Thank you, Hayden.
Thanks.
All right. And I didn't miss anybody, did I?
I don't think so, Kelly.
This is Molly. Can you hear me now?
Oh, yes, we can hear you.
Oh, good. I'm just still getting used to these virtual meetings. So I'm Molly Wing. I'm from Columbia Memorial Hospital. I've been here about 10 years, and I started in finance and accounting and kind of worked my way into, I'm a senior business systems analyst, work more on the data and reporting side, but I like to join these meetings just to kind of see what our departments are needing from us and how we can support them. So I'm just here to listen to what's going on with you guys.
Awesome. Welcome, Molly. Thank you. Okay, well, what we planned for today is we're going to start by just talking about the organizational structures for our different organizations. And the idea was that we recognize that there is no one standard model for rev cycle. Every hospital has its own different flavor and setup. And so we wanted to just share what do some of those different models look like. And so I know we have one for OHSU that we can share. I think, Eric, you have one for Legacy that you will be able to share. And then I don't know, Molly, if you have one for Columbia Memorial, but you're welcome to share if you have that. We'll make sure to give you some time. But I'll go ahead and kick us off here. And then, Tara, I'm so happy to have you on this call since you can keep me honest with the patient access setup at OHSU.
Happy to do so.
And then, Hayden, it looks like I'm disabled from being able to screen share. Can you grant me the access?
There you go, Kelly. Should have it now.
That is power. Okay, can everybody see this?
Yep.
Excellent. So I am sharing the org chart for OHSU Patient Access Services. Christy Cushman is our director at OHSU. So this is a visual of her teams. They're so big that they are on 2 pages, so I'll make sure to cover both pages. But I did a quick little addition here in patient access at OHSU. We support both OHSU. We also support Hillsborough Medical Clinic. And in total, all the teams make up about 175 FTE. So very, very big group here. And the teams are broken out by function. So we have in patient access, Christy's over centralized managed care. She's over centralized check-in. She's also over PAS and ED, and then patient financial services. So I'll cover the first couple, and then Tara, I'll let you introduce your team and your function, and please feel free to chime in at any time. But managed care at OHSU, it's been an evolution for sure. So it used to be that the managed care staff actually reported up through the clinical departments. And it was the department's responsibility to get the authorizations in place for patients prior to getting their services. And that's the way that we did it for a long time, with the model that the departments cared about their revenue and should be responsible for getting the authorizations. They knew their lines of service the best. And slowly over time, we have been transitioning much of that work into a centralized managed care department. And the reality was the staff in the departments, when you're faced with tasks of having to get authorizations or check in a patient or deal with a complaint, the focus is always patient first. And so we had departments that struggled to get the authorizations in place on time and to have all the right skill sets and understand all the complexities of what was required to get a strong authorization in place that would cover the service. We were seeing high volume of adjustments for missing authorizations, and it seemed like a good place for us to really focus efforts to bring in a managed care team. And so I think we are about 50% or slightly higher than 50% now of all managed care functions happening through this group, and the remaining still happening in those departments that want to own it on their own. Is that right, Tara? We're a little more than 50%?
Yeah, and I know that there's kind of an almost a wait list now for those so additional clinics to get rolled up into centralized managed care because they've been incredibly successful in this model. They've been much more efficient with consistent documentation and getting those authorizations in a timely manner. And so more and more clinics are going, yes, please, here, take this work from us. Here, have this FTE. That's fine. Here you go.
Yeah, and it was interesting because as we started down this path, the centralized the department said, we will take on the functions, but it means we need to take your FTE because we have to have people who can do this. And so there were departments that were reluctant to give up their FTE and also reluctant that, would you really do it as good as we are doing it? And like Tara said, now that we've been doing this for a few years, we've seen some very good results. We've seen a significant decrease in the adjustments. We do have more departments saying, yeah, please take it. We'd love you to be the expert in that area. So that's been a success story for us, I would say, for sure. And then one of our newer groups at OHSU, we have a centralized check-in team. And so we have 3 locations that have a centralized check-in model, one out at OHSU Beaverton, and then one at CHH, and then we have floats that travel where they're needed most. But centralized check-in is a new model where, historically we break up the staff functions by you do registration and you do check-in and you do authorizations. And this centralized check-in, the idea, the model behind that is that it's a one-stop shop. These buildings, the Beaverton location and our new building down at CHH South on the waterfront, patients arrive at a single check-in desk and that person does everything for them. They're able to do the registration, they're able to do the check-in, they're able to tell the patients where their appointments are. I think also, Tara, they're the ones make sure that the authorizations are in place so that once you check in at that desk, you're set for the day and then you have your appointments throughout and you don't need to continue to check in and answer all the same questions because they've done everything at that one location.
Yeah. Most of the authorization stuff is owned by either the central managed care team or the individual clinics, but that central point for check-in really decreased the amount of touches that the patient would have if they have, say, 3 different appointments that they're going to in that one building. They do a quick. It's like, it was amazing. I got to experience it myself with my kids, and it was like 2 minutes. I was in and out and done, and I just went where I needed to go, and it was a very, very smooth process versus having to check in at all these different locations. And they use a signaling process within Epic so that when the patient arrives to radiology will go, oh yes, this patient is now here. And then as soon as they leave, radiology will trigger and say, oh, okay, now this patient's going to their primary care clinic, so that then that next group that's going to be receiving that patient knows that the patient is en route to them. So.
Yeah, excellent. And you're able to make any co-payments at that one location as well?
Yep.
Yep. That's good. It's especially good for those areas that have day patient procedures where your patient's going to have to go to lab and radiology and pre-op and have your procedure all in one day. You only have to make that one stop with the check-in staff. So it's been a good model. We kicked that off last year. I don't remember the month, but it's still fairly new for us. We've been piloting for a little while though.
I think it was somewhere around the February timeframe, because I know when I went through my interview process, things were in full swing around April. So I think they went live in either February or March with that model.
Excellent. And then Tara, how about you introduce your group, and also if you want to take December's too, since I know you partner so closely.
Yeah, absolutely. I actually have a vacancy on my leadership team right now. So my ED Reg supervisor is currently being occupied by yours truly. So I'm kind of wearing two hats right now. And we actually have 16 staff that work in our emergency department. And almost everything we do is bedside reg. We have 2 primary locations where patients can get arrived, either at our arrival window or in the back with our ambulance bay. And then almost everything else we do bedside as soon as triage is over and done with, yay for EMTALA requirements. And then our admitting department, we service 3 major areas. We service Dornbecker Children's Hospital, we service KCI Institute, and then we also have our main admitting area where we service all of our operating rooms, direct admissions, etc. We also service our multnomah pavilion for outpatient GI procedures, but we don't, right now everything is going through admitting because COVID. So that's the vast majority of what we are, what we own. We don't really do anything with authorizations. That is all owned by the IVS team and managed care group. But we do a lot of check-ins, and just recently we started doing all of the VA notifications for urgent and ED admissions. Those were going through the IVS team, but due to the new requirements, that's something else that our team has recently taken on, which is going just swimmingly. And then December's group is our ambulatory registration team and also the patient financial services group. So we do kind of work in tandem where we do a lot of Medicaid applications ourselves, and we also do work with, what are they called now? MedData? Yeah, for the weekends where they process the applications for patients that come in over the weekend that are uninsured. And then December's team is the predominant one who does most of the batching for insurance verifications at the beginning of the month to make sure all of our patients' insurance is good to go. My team also does that obviously as well for ED patients and direct admissions patients that are coming into the hospital. And then the IVS kind of does the final touch and does the notifications on those as well. So that's kind of our group. Oh, and December also does quite a bit of work with the Tuality financial services component. They all report up through her as well for financial processors and whatnot. So she's got her hands full.
Tara, do you want to talk a little bit too about the schedulation model? I know we're not doing that at OHSU, but at Tuality.
I can talk a little bit about it. I don't know a lot about it. Tuality earlier, late last year, I don't know, time is a blur. Within the last year, moved to a schedulation model where they have a centralized area where patients can call in and get set up as new patients, get their registration done, and get scheduled for their appointments all in one fell swoop, versus having to call the clinic, get their appointment set up, and then go, okay, we actually need you to call registration first to get established with a medical record number so that we can get you scheduled at our clinic. So there were quite a bit of bumps with that process in the beginning, but I think at this point it's actually gone pretty smoothly out at Tuality. They've got pretty decent service level, even with some technology issues with people moving to working from home and having phone issues. But it's been, as far as I can tell, a pretty successful model out of HMC.
Yeah, that is great. Thank you so much, Tara. And
yeah, absolutely.
Curious from Eric and Amanda and Molly. So the concept of schedulation, having staff that could do both scheduling and registration. OHSU's talked about this for years. We've wanted to do it, but it's been very hard to implement. And that is some pretty big change to have a centralized group do that. We've had a lot of departments that are passionate about having their schedulers that know their doctor's schedules and know all the idiosyncrasies. And the idea of pulling that out and having a centralized team trained to do scheduling and reg is just something that has been hard for us to overcome. So we were thrilled when Tuality came on board and said, hey, we want to do it. This is what we're used to, and we want to be able to have that functionality. So we were able to do it and have it be quite successful. So I think we will get there eventually, but I'm curious to know if any of your organizations are doing schedulation or not. So when you cover your presentation, point that out. Before I hand it off to Eric, are there any questions about our OHSU model?
So Kelly, this is Amanda. So how many managers are there?
There are 4.
Yeah, there's 4.
I saw 4 to make sure I understand.
Yep, Ryan managed care and price estimates. Karen over the centralized check-in. Tara's over PAS and ED, and then December over registration and insurance verification and financial assistance.
Yeah. And almost each of us has 2 supervisors. Most of us have a coordinator. And then myself and December have trainers on our team as well that report up through us.
Okay, and then, so I see like the ED reg and that type of thing, but then for December, I see that she has PFS folks like at Tuality. So are there other managers as well that are at well, I'm sorry, I know it's called something different now, but
Hillsborough Medical Center.
Yeah. Yes, thank you.
yes, there is a single manager out at Tuality, and she has 3 supervisors, one that is over the schedulation area, one over the admitting in 7th Avenue, which is kind of like their outpatient area, and then a third over the emergency department. Adventist hasn't fully rolled under in that bracket just because everything kind of got postponed because of COVID. But sure. They have what they consider to be a director out there, which is it's essentially equivalent to a manager at OHSU. And then they also have 3 supervisors.
Okay, and then do they report up to Christy, or is it totally separate?
At this point, it's totally separate.
Okay, thank you.
Yeah, we have conversations with them sometimes, but it's very, at this point, it's still pretty separated.
Thanks so much.
All right, Eric, I'll hand it off to you.
Sounds good. Let's see if I can share my screen. And I'll probably need Amanda, and I think I saw Mel. I think she's on here too, so. Looks like I need
I'm here.
Hayden.
Gotcha, Eric. And now you have it.
Okay, there we go. Let me know if you guys can see my screen. Perfect. All right. So for patient access and financial counseling at Legacy, I guess we can start up at the top. We all report through Terry Handy, our VP of Revenue Cycle, and then Amanda Gordon. She is our Director for Patient Access and Financial Counseling, Customer Service, and Interpreter Services. Amanda, you could probably tell us how many, I guess, FTEs we probably have under you.
Yep, we just had to do a count for our wine distribution. So we have 309 that report up through us. And the one thing that's not on the org chart, which I don't think anybody here probably cares about, is the interpreters. We do have a coordinator of interpretive services, but a couple of the managers also manage interpreters at their sites as well. The patient, that does roll up to the patient access managers.
Yeah, and so I know, I guess each facility is kind of set up a little bit differently. Good Sam, for example, they've got a patient access manager and a supervisor. Same goes here at Mount Hood. It's myself and one supervisor. Emmanuel, they actually have one manager and two supervisors, and then Unity has just the manager, and Meridian Park has manager and supervisor, and Silverton currently is just the one manager as well. Most of us have, I think, a main admitting area where you check in. And then in addition to that, we also oversee the ED registration. And then some of us have some MOB registration check-in points as well. Here at Mount Hood, for example, I have a breast health and imaging center that's in our MOB location. And then our endo and ICVR procedures, those check in through a MOB location as well. So we're all set up a little bit differently just based on what our campus is. Some of us, Silverton, for example, I think they've just been reassigned a new location for them as well, just to have it be more centralized through them and kind of replicate some of the other patient access sites. And then Melody, she's the manager for financial counseling. Melody, do you want to give a little bit of background on financial counseling for you?
Sure. I am, like I said, manager for all of the hospital sites, and so I have financial counselors at each hospital site, 3 at Emmanuel, 2 at Good Sam, 1 at Meridian Park, 2 at Mount Hood, 1 at Salmon Creek, 1 at Unity, and 2 at Silverton. Oh, sorry about that. Okay. Anything? I just wasn't sure if anything else you wanted to.
No, I think that's good. Thanks, Melody. And then in addition, we have Cameron McLennan. He is the manager for hospital billing and professional billing, collections and customer service. So I think, I guess from Amanda, we have both a front end perspective, but then also with the customer service on the back end, it's kind of, we're on both sides there.
And I also forgot, because you mentioned MedData. We do a contract with MedData just at 2 hospital sites where we have the highest volume of indigent population. So at Emmanuel and at Mount Hood. So we have one, and they sit near the ED area to help us with the OHP applications right when patients come in. So that's at Emmanuel and at Mount Hood. Just wanted to add that on too.
Thanks, Mel.
Mm-hmm.
What else? Amanda, anything else, I guess?
No, Eric, you did a great job. Thank you.
Okay.
Sorry about that. You can see me.
Hi, Melody. Any questions from anybody?
It's Kelly. It's so nice to see the visual. I've met some of you through HFMA, but now to understand where you sit and how you're structured is really helpful to me. So you basically have that patient access telecom manager at each location, and you do have the centralized registration setup. What about managed care? What's that model look like at Legacy?
So would that, I guess that would really fall probably more so under Evan, right, Amanda? We really don't have.
Yeah, we work really closely with them, Kelly, but we don't have managed care within the revenue cycle. We have, bits and pieces, and like I said, work closely with them, but it doesn't really report up centrally through revenue cycle. The other thing that's a bit odd, I would describe us as like the patient-facing pieces of the revenues under customer service as well. But the Deidre Melson, who's the manager of the insurance verification and pre-access team, reports up through Evan. which is a little bit odd sometimes when you think about, pre-reg and IV. But that's just how we have decided to move forward right now.
Mm-hmm. So then, would you say the majority of the managed care functions to obtain authorizations are still in the clinics?
So for the hospitals, Deidre's team works on that under Evan.
Okay.
But and it's shared with the clinics as well. So for people who are already in-house, that type of thing. And Melody's team does that a little bit as well. They do work pretty closely together, Deidre and Melody. But from a clinic standpoint, we have a lot of support in the clinic, but I was interested in kind of what your model is. And I know I've mentioned to the team that it's getting really big and difficult looking at kind of our structure. And I think you'll see that we don't have an analyst where the other rev cycle teams do. We have a self-pay analyst, but not a specific analyst to patient access. We get support, of course, from Ivona, from project management, and Carmen, but they don't report to us, and we need help. So we're looking at what other options we might be able to have to get creative. So anyhow, we're just starting to look at that. So that's why I was asking some questions about the other org chart.
And then the other thing curious about from a registration perspective is I know one of the big reasons that we centralized registration was just because of, really the training and education you have to have when setting up accounts and coverages and plans. And so that training was important to make sure we had a centralized model. Everybody was trained on the same thing. I assume all your teams, even though you have separate managers and locations, is there a central training that they all get the same type of training and education and communications, or do you operate at a location basis?
So I guess we all start with an initial kind of centralized training, but each facility really handles their own training. I think right now during COVID is really when we've been kind of sharing staff more so, because some sites have been lower with volumes. So we've been able to borrow staff, especially, where we weren't able to hire for a short time period. So I think, right now, I think that's, those are conversations that we've actually had with Amanda about, having kind of more a central standard model for our teams. But we've been able to make it work, and we've been doing some kind of hands-on training with some of the staff when I've had folks come from another site over. But the good thing is that most of our workflows are pretty similar. So people are able to help and kind of catch on fairly quickly. I know that we've even currently are having some Silverton staff helping do some phone registers even out here for Mount Hood right now. So they're able to jump in and help out even from a remote standpoint.
Awesome. Good cross coverage there. Any other questions from anybody on the legacy model? And then Molly, I don't know if you have anything for Columbia Memorial. It sounded like you were a little bit outside of patient access, but is there anything that you wanted to share?
Yeah, I think that it's probably not my area to share. I don't think that I would get it exactly right. So probably nothing from me.
No, not a problem. We're still happy to have you here and to give you the chance to see a couple different models. It definitely varies. All right. Well, I know we were planning to end about 12:50 today. I want to make sure we left plenty of time for questions. And then the other thing we wanted to do was just open it up to the group for any discussion on best practices that you would like to share, or if you are experiencing any pain points right now and have some listening ears who might be able to offer some suggestions on workflows or technology. Anybody have any questions for us?
Always ready to talk technology.
This is Melody. I had a question for whoever is able to answer on self-pay scheduled procedures. What do you guys use to determine medical necessity? How do you determine medical necessity for those scheduled services? Do you use the OHP above or below the line? Years ago when I spoke with, I spoke with December years ago, but there's someone else I spoke with that OHSU was using the OHP above or below the line finder. And if the procedures were below the line, that was the determination that those procedures were not medically necessary and therefore could not go forward unless there was payment plan and that type of thing set up. So I was just curious what is used now.
Yeah, Tara, that's my understanding is we're still using OHP above or below the line for determinations of financial assistance. Is that anything different?
I do not know, honestly, because I am not the one who makes that determination.
Yeah.
My team's just the one that says, yes, they're good to go. We collect the dollars. Okay, cool. I know that there has been discussion about whether a patient is above or below the line. I know for financial assistance, that's definitely a component. As far as patients that are uninsured and proceeding forward with, from a medical necessity perspective, I think it's a fair assumption that that's still the direction we're going, but I do not know that for sure.
So Tara, I actually just talked to Christy about that not too long ago because we had a question come up. And so I apologize, Mel, that might not have gotten back to you, but that was that was what Christy shared with me, is it was still the Medicaid kind of eligible above and below the line. Mm-hmm.
Yeah. It's not something that would typically hit my ears because it's not my scope. So it's totally reasonable that I would not know that one for sure.
Yeah. We just have to get on a call with Legacy to find out what we do, Tara.
Yeah, it's perfect. Got any other insider tips, Amanda? You want to tell me anything else?
No, we had something come up actually and thought that you guys might be leading the way. How it came up was for both international patients and also looking at different gender services. And so anyway, that was why we were initially reaching out to ask. So Mel, that was a result of that conversation we had a few months ago with Katie O'Neill and looking at the transgender program at Legacy. And so anyhow, that's how it sparked. And so I reached out to Christy.
There's just a lot of, only reason I was asking, there's just a lot of services that are below the line that still really are medically necessary, even though OHP is not able to cover them. Hernia repair is one, and a lot of cyst removals. And I just was curious how you handle those, since they are not medically necessary for OHP, but really are a medically necessary service. So I was just curious of how you handled those. So that was.
Thank you. Thank you for the question.
Hey, Tara, I guess maybe for OHSU, are you guys currently, I knew with this new Senate Bill 1606, are you guys currently asking the question about what the disability is from patients yet?
No.
Or are you guys having that conversation?
We worked through our AAEO department and our legal team, and we have a very broad statement that basically says there's this new law that allows patients with disabilities to identify 3 support persons. Would you like to identify 3 support persons? That way, at this point, we aren't actually asking what those disabilities are. I know there is some additional information about what condition is imposed on the support person. that is called out in the Senate bill, we are working with our analysts to try and get a better way for us to be able to designate, okay, this person is needed for interpretive reasons. This patient is a person that's suffering from, hearing loss. And so we need, or a caregiver. This person, provides, medical support versus emotional support. We just haven't gotten to that particular level yet. And we've reached out to our friends in the Epic world to see what they recommend as far as how to document and where to document. And their general response was, yeah, we don't have anything like this designated except for the roles that live within the emergency contact or patient contact field. So it's been a lot of fun trying to navigate that in the last couple of months. But yeah, so we don't specifically ask what their disability is. Just we inform all of our patients that this is a right that patients with disabilities have and kind of allow them to lead that conversation.
Gotcha. So I guess, is your clinical staff going to be the ones documenting that information? Like, how are they going to correlate the two to meet the needs of the bill?
Mm-hmm. Yep. That is exactly the question that we are working right now to get resolved. At this point, we have built in our patient contact field the designation of emergency contact and support person, which pulls onto the IVS, so that our anybody can see, because pretty much everybody has access to the emergency contact fields. Currently, our team is the only one that can modify the designation of support person as a role within Epic. But it's a very, it's just a very basic thing just to meet that basic. Yes, we did ask if the patient wanted to designate a support person, so that at the very least we have that in the documentation. There's specific instances about at the time of scheduling asking that information. We have not come to a great process, since the scheduling component is owned by every clinic under the sun, and trying to get all of those different components identified has been a little bit challenging for us, which we're hoping to get resolved within the next week. We have a meeting about it, I think next Tuesday, actually, where we're pulling in some bigger horses to really make those decisions, because we are not meeting all the elements that we need to at this point.
Awesome. Thank you, Tara.
Yeah. What are you guys doing?
Well, we're asking and we're documenting.
Okay, cool. All right, so we're in the same place.
We're using that similar role. Now we have one created that was a support person. Our clinical staff, actually, they do have access to be able to document or to update the support person role, just like they can update the allowed visitor role.
Yeah.
So they can do that, but it's also up in the air in regards to who will be documenting the actual disability associated.
Yep. We have a very strong split right down the middle of where people feel that needs to live. So we'll see where that actually lands. Since most providers are working with that patient, they're already familiar with what those disabilities are. They're the ones that are going to know some of that information. It makes sense to me to have that on the clinical side. We have some very strong opinions that feel it should be documented by our team. So
yeah, that's how we're kind of in the same boat.
Yeah, it's fun. Yeah.
All right. Well, I know we are just about at time. Are there any other questions? I did want to solicit feedback from you all. So when you think about your teams at your organizations, within enterprise revenue cycle, within patient access, whether frontline or lead or supervisor or manager, do you think that offering a venue like this would be valuable to them? I mean, would it be interesting to know kind of who's like me at another organization, or would a problem-solving kind of a model be of interest to your staff, or are there other things that we could do with breakout sessions to bring value to your teams? What do you think? Anything come to mind?
I think for us, I think we're new to the enterprise membership. So I think it's being able to get that knowledge out to, I think, for example, my supervisor here at Mount Hood, I think this is her, she joined one of the other sessions, I think, rather than patient access. But I think it's also, I think she's trying to just get a feel of what other stuff is out there. So I think it's just being able to get that information out to everybody and let them know that these sessions are happening and that, you can communicate with others from other organizations and, ask questions and get to know people and, have someone to reach out to when things come up.
Yeah, I would agree. I think this is what I'm doing at my facility. What are you doing at your facility is really helpful. I know when we did HFMA back in, I think it was October, I was still so new to the organization. I didn't even know what to talk about. And now I've already got like a draft email going in my head of other things I'm going to ask Eric about how they're doing things at Legacy to make sure that there are any other things that we haven't thought about on our side that have come up that have been new, either with COVID or with the new veterans requirements or the new House or Senate Bill 1606 or the new House bill that's coming down the pipe in October. All those, it's nice knowing, okay, hey, this is somebody who might have some insight, or I can pick their brain or see what things did and didn't work for them. That part's really, really beneficial.
Awesome, Tara. Success. You met Eric. The other thing the enterprise membership committees talked about is reaching out to these subgroups and saying, okay, let's pick a topic. What's something that would be really good training to offer to your staff, and host a 1-hour online training that's targeted towards something that affects registration or patient access or financial counseling. So if we were to reach out to you and say, what topic do you think we should address or vote? Is that something you'd be interested in? And then opening up and inviting more of your employees to attend?
Yeah, I think that would be good. I know that at least with my leads, like I've recently met with them. I meet with them usually once a month, and I know that that's been just some of the feedback is kind of, we used to have training sessions right prior to COVID, and they would be, kind of like one of the instructors that would come back and teach it to our staff, and we've kind of had to pause that. So I think being able to have something that they can, find valuable, and then be able to come back and teach it to the other staff, I think that would be helpful.
Yeah, I would agree.
All right. Well, I enjoyed spending the last hour with you. If there's no other parting comments, we'll let you go. But thank you, everybody, so much for participation, and stay safe. Tara, keep in safe distance from any danger.
Yep, we'll do. I'm actually to the point now. I'm like, I'm gonna go pack my car because.
Oh no.
Yeah. I just pulled up the fire map and I'm like, I don't like the direction this is going.
Yeah, no, get out of here. Stay safe.
Yep.
Yeah,
We'll see.
definitely.
All right.
All right. Thank you,
Have a good one,
everybody.
guys.
Really appreciate it. Thanks, Eric. Thanks,
Bye.
Hayden.
Thank you.
Bye.
Bye. Bye, Kelly. Bye, Molly.
Bye-bye.